So we'll still have a few extra people joining us, but I want to thank you all for being here. Really excited to have as many people involved in the class as we are, and really getting into some of the meat of the matter. This is designed to be a real conversation as to being a discussion. And I will consider it a success if I'm not the one talking most of the time. And so I look forward to you helping me do that. I do ask that when you are not speaking to go ahead and have your microphone muted, just to cut down on background noise. And if you can use the chat window, that's a great way of asking questions. And then that's especially good because if it's something that I know that I'm going to be coming up on, I can connect it, we can add it at the appropriate time. All right, so without further ado, welcome back. So we have some of the familiar faces, and we also have some new faces. At this point, Michael, if you want to go ahead and introduce yourself as he finds them.
How are you? How is everybody tonight? My name is Michael Lambrex. I'm the EMS Battalion Chief here for Woodside Fire. I'm also a captain with the fire department. I'm just being reassigned for the next 4 months. With that said, I've been a paramedic since 2007 and been working on an ALS engine and an ALS ambulance my whole career. I've been teaching CERT now for probably close to 6 to 7 years. And I want to say thank you guys very much for everything that you guys are doing. Thank you very much for taking the class. And if there's anything I could do to help, please feel free to always reach out.
Fantastic. So just as a heads up, we are modifying the schedule just a little bit. When we started looking at the units, we realized that, we really want to spend a lot of time on Unit 3. So we've made a slight modification, and we anticipate that tonight, we're going to be really focusing on the addressing life-threatening conditions and basic first aid and some of the more operational questions, talking about mass casualty, and then also the more detailed assessment. We're going to put that off till next week and have that join in with disaster psychology. Before we get going, though, I do want to point out that a lot of the material, the online course, of course, is very strong, very fabulous, but there's even more content within your participant manual. When you go and log on to the website, there's a link so that you can download a full PDF of the training. This is also very helpful if you find yourself scratching your head at any of the quizzes, that you can follow the link to the manual as well. So that's just a resource I want to make sure that everyone is aware of and has a copy of.
Is it basically the same as the manual that I got when I did the training in 2017?
It may be slightly different only because it's the 2019 version of it, but I anticipate that it's very, very similar. So as I said, what we're going to really focus on tonight is what are life-threatening conditions and a little bit about then basic first aid. I really want to emphasize that this is a broad overview. I mean, honestly, the content within this unit could be covered in a 40-hour first responder course. So don't feel daunted if this is a lot of material, because it is a lot of material. A lot of this content we're going to cover when we get hands-on, and when we talk about what are some of the hands-on skills. This is a great introduction for you to be aware of the concepts, but then we're going to reinforce it and we're going to really work on it in the hands-on session of the class. So when you think about what are the life-threatening conditions, one of the things that you have to think, actually take a step back. Before you're even approaching that patient, always, you have to think about scene safety, because you don't want to become another victim. Not only is it embarrassing, but it also is you are adding to the problem. You want to be part of the solution. So I always like to say, don't just do something, but stand there. Before you approach, really ask yourself the question, is this safe for me, for my partner, for the patient? Is this somewhere that I want to be responding here and now? Another way of being safe is to making sure that you have your personal protective equipment on. So at this point, I want to hand it over to Michael, and we're going to talk about some of the nuance and some of the details of how to successfully approach a patient.
So thank you for that, Cam. And one thing I always like to add, Cam hit it right on the head. Scene safety, making sure you're safe, and you don't want to become part of the problem. You want to be part of the solution. When you size up a scene, it's not just looking in front of you. You want to look to the left, you want to look to the right, you want to look up, and you want to look down. Give it a good 360 of the survey of the scene. So really want to hammer that home. You want to make sure it's safe for you, your partner, and the patient. From there, I always like to talk about, especially in the EMS field, approaching the patient, right? We always take several steps to take when approaching a patient. The first thing is the patient conscious or unconscious? Let's talk about a conscious patient. If the conscious patient is able to see you, make sure you make eye contact with them from a distance. I'm talking maybe 10, 6 feet away. Make eye contact and then identify yourself. Say, hello, my name is Michael Lambricks. I'm with the fire department. May I help you? And the reason why you want to do it from a distance is when CERT is deployed, when we are in that emergency setting, people are on high alert. People are going to be kind of sizing each other up and who's who and what's what. So they want to feel comfortable before they let you in their personal space. So identify yourself, make eye contact, get approval, and then approach the patient. When approaching the patient, you always want to approach from the front, not the back. You don't want to surprise them. And then when you walk up to them, you always want to make sure you keep that distance, that 3 feet safety zone. And when you approach them and you start asking them questions, you want to be at a side a little bit. And the reason why you want to be at a side, almost like that 45-degree angle when you come up to them, is because I always like to say you want to stay out of the hot zone. And what is that? That's if somebody decides to cough, sneeze, vomit. You don't want to be in the way of that. So if you are on the side of that, you could protect yourself. Again, being safe and keeping yourself so you don't get exposed to certain things. From there, I always like to talk about when you do an assessment or approaching a patient, I always do 4 questions, right? Our A and O questions, because this is going to allow you to identify if the patient's altered or if they're not. I always like to teach, let's keep our questions very basic and keep them the same because that'll keep you organized. I always start with the person's name. First, identify yourself, then ask the patient's name. From there, ask them how old they are and, give it to them. If, they're 80 years old and they say they're 81 or 78, they're not altered. We're going to go ahead and give them that. But if they look like they're 78 and they tell you they're 43, hey, there's something wrong here. So I ask the name, their age. I always ask where they're at because people should know where they're at. And then I always ask what happened. I always stay away from questions like, who's the president, right? We live in a very diverse area. People could be coming in and out of the country and might not know who our president is. I always like to stay away from day of the week. And the reason why I stay away from day of the week is, I'm a firefighter. So I know it's day 2 of C shift, but I don't know that it's necessarily Monday. Maybe somebody who's retired might think it's a Tuesday when it's a Saturday. So I always try to stay away from day of the week. Then when you're talking to the actual patient, I always like to say, never stand over the top of somebody. So if the person's sitting in the chair, never stand over the top. Body language says a lot. When you stand over somebody, your body language is displaying dominance, and that could make somebody feel uncomfortable, right? So I always like to say, keeping at your angle, drop to a knee and get eye level with them because it helps you build a better rapport, builds trust and it lowers people's kind of heightened awareness, and they'll start opening up to you a little bit about the medical condition because you're a stranger trying to help somebody. So you're building that rapport, you're building that trust. And it says here, and then also when possible, respect cultural differences. You always want to understand that, different religions have different things, male versus female, and female versus female. You could have somebody who, I'm a 220-pound man talking to a female, and she might not be comfortable if I start touching her and talking to her. So you really want to be respectful of that. And so if she says, no, you know what, I'd rather have a female assess me, always respect those differences. And then when you're doing a patient assessment, I always like to say you want to walk the patient through everything you're doing. Again, you are a stranger trying to help, but let's say I'm a 220-pound male and I have a female and I'm touching her trying to do an assessment. It might make her feel very uncomfortable. So what do I always talk about? I always say, I'm touching the back of your head for this reason and I'm looking for this. I'm touching your shoulders for this reason and I'm looking for this. You walk them through it to make them feel more comfortable. Now, people always ask me in my classes, what happens if there's a language barrier? Then you want to kind of do maybe simple commands. Hold up your hands and say, can you squeeze my hands? And show them squeezing your hands, and then put out your hands and let them squeeze your hands. See if they could follow simple commands. And then always remember, whatever a patient tells you, that is confidential information, and never really go around talking about it. Or, I ran on Mrs. Smith that lives over here and she told me X, Y, and Z. Remember, there's that confidentiality and there's that HIPAA. So you always want to respect that at the very end. Again, approaching a patient. And does anybody have any questions?
Actually, Michael, before we go to questions, Michael, I wanted to ask you to add one other component. And because sometimes when we approach someone and they're not responsive, what is a safe way of approaching a patient who's unconscious?
Great question, Cam. So what I always like to teach in my classes, if someone's unconscious, right, whether it's in an emergency setting or maybe you're on a trail hiking and you see somebody, I always like to teach, and this is for your safety, is you approach people at the feet first. So if somebody's laying down, I always tap them on their feet first with my feet. And that's because if, say you were on a trail and you were hiking and someone was laying underneath a tree, and I went straight to your shoulders and I tapped you on the shoulders and I put my face in your face, you're going to wake up startled and potentially maybe fight back because you don't know. So I always say start at someone's feet, kick their feet. If they wake up, then you could start talking to them from there. If they don't wake up, then I go ahead and move to the shoulders first. But always start at the feet, and that's for your safety. And then you work your way up to the head. Did that answer the question there, Cam?
Yes, thank you. So going back to just just opening the floor to questions that people have about approaching patients.
What is the best way to introduce ourselves? To say, I am CERT trained, I am trained in emergencies, what would you use?
Absolutely. Great question, right? Carol, I believe that's who asked the question.
Yes.
So if I was in your shoes, right, and I would make eye contact with them and say, hi, my name's Carol. I'm with the CERT team number 6. I have CERT training. It looks like you need some help. May I come help you? And you establish it from there. You let them know your CERT number, the team you're with, and then they're going to say yes. They're going to obviously see you in your vest, your helmet. So you're going to be wearing some sort of uniform. And then from there, that's when you go ahead and approach. Now, if someone says, no, I do not want you to come near me, I don't need any help, you do need to respect that, especially if they're answering questions appropriately. And then from there, I always like to say, be a very good witness. And if you notice that maybe they do need help, call somebody else and maybe they can talk them into it. But don't get overly aggressive and don't kind of push it on somebody, because we want to make sure they feel safe and ultimately it keeps you safe.
And this is Andrew. I have another quick question. And I think we may have touched on this a little bit last week. You mentioned that, we're going to be in our vest, we're going to be in our hat. Are we limited to doing this during a certain activation, or is this kind of at any point in time if we see somebody who needs help?
Well, and that's a great question, right? Maybe you're at Safeway, right? And you see someone that needs help. Maybe you're, shopping or see, right? So I would always just say whenever I would take a rule of thumb, whenever you see someone that might need help, I would always do this. And you can say, hi, my name is Michael. I'm trained in first aid, CPR. I'm part of a CERT team. Looks like you need some help. May I help you? You can identify yourself that way. But just always identifying yourself, making eye contact, and then seeing if that person's receptive to you coming over and helping them.
Yeah, Mikey, if I can just add to that, this is a good point that we talked about last week, which is self-deployment to an incident. And as a CERT team member, we do not do that. So you would not, in that case, present yourself as a CERT team member or acting like you're part of the CERT program. But just as Mikey said, you can definitely say, hi, I'm Mark. I have basic medical training. I can help you if you'd like some assistance, but you're not going to be working as part of a CERT team member in that type of incident. That would be a self-deployment, which is what we don't do.
Excellent point.
Okay, yeah, that's helpful. Thank you.
And also, if someone is unconscious, that implies tacit consent. Is that right?
Yes. If someone's unconscious, right, they got hit in the head, something fell on them, it's implied that they would want help in that situation. So you are protected.
Any other questions about approaching the patient? Okay. So as you read about in unit and viewed in unit 3, a lot of it is addressing life-threatening conditions. And so a lot of it is, I like to think about it as you want to buy time. And so what are the things, and you really think about it, is like, what could kill this person in the next few minutes? And it really is anything that's going to prevent that oxygen-rich blood from reaching the vital organs. I like to think of it, actually, let me go back. So I like to think about it as, how do we get oxygen? We get oxygen by breathing. So the oxygen needs to go in and out, and the blood needs to go round and round. And so for that very first step, you need to think about it as like, is the airway open? And so when we think about what are the things that we can do that can have a profound effect on someone's survival, is just the simple act of doing a head tilt chin lift, of opening the airway, can be a life-saving maneuver. Bleeding. This is something that we are going to be addressing a number of times. And basically, when you talk about, is there enough blood in the body to carry that oxygen to the vital organs? And then one that's a little bit subtler than blood on the ground is shock. And that also is not only do you have the blood in your system, but is it getting to the right places? So when you talk about opening someone's airway, when we do our hands-on skills, we'll practice doing the head tilt chin lift. And one of the things that is important to realize is that even if someone is making snoring sounds, that the most likely thing that is causing that obstruction is the tongue. And so the act of doing that head tilt chin lift can move the tongue off the back of the throat. Actually, Vicki, Michael, or anyone, do you want to add anything about airway before I go on?
No, you hit it right on the head. 9 times out of 10, when somebody goes unconscious, right, their tongue becomes almost flaccid and rolls backwards. So you're just repositioning the head. So absolutely.
And also, it's not advised to reach into somebody's mouth if you think they're choking on something, an object, unless you can see it and you know you can grab it. You should never sweep the back of the mouth.
Very good point. So on to the more dramatic. With controlling bleeding, when you think about how much blood someone has in their body and you see someone on the ground, one thing to be aware of is the kind of ground that they're on. Is that if you take, in fact, actually, I'd encourage you, go ahead and at some point take 2 liters of water, like in an old 2-liter jug, and just go out to some soil and pour it down and just see how quickly it absorbs in. You might not know how much blood someone has lost. On the flip side, blood can also, if you're on a slick surface, something can look incredibly bloody. And it's, yes, there's blood, but it might not be as much as you think. So just be aware that just visuals alone isn't enough to tell you how much blood loss there's been. And the other thing is that when you are when you have your gloves on, you can actually use your gloves as a way of you're looking for the bleeding. You're looking to find out where is someone bleeding from, and if you're doing a swipe down their back, don't just do it as all the way along, but look and then look at your gloves. Are they bloody? Are they bloody? And so that way you can use them as a way of actually finding out where the bleeding is taking place.
Cam, may I say
Please.
something? We talk a lot about using our hands to identify blood and where it could be. Always remember too, what you touch after you touch somebody and you touched blood. Now that's on your gloves. You don't want to touch your equipment. So maybe having someone at your equipment handing you stuff, so you don't want to touch other people, other things in your equipment. It's also a part of your PPE and keeping yourself safe for the prolonged of that incident.
Your scribe is your best friend. So with controlling bleeding, you'll hear that we talk about really 2 things. One is direct pressure and the other is tourniquet. And it cannot be emphasized enough how valuable well-aimed, firm, direct pressure is. And one of the things to be aware of is that it has to be actually on the wound itself. It is you are helping the clot form by slowing down the bleeding. There was a really good question that Donnie brought up in the online forum, and sorry I didn't get a chance to write back to it, but that idea of, there's the question of, so you've put ideally a sterile gauze, a sterile dressing on that wound, and you're putting direct pressure. And if it bleeds through, we're trained to then add to it. That said, you don't want to have a big pile that you're having the blood flowing into it. There's the question of, are you actually getting direct pressure on that point? So think of it in terms of, am I getting well-aimed direct pressure? Am I in the right place? And also, you want to keep that pressure for longer than you might think. One of the things that happens when we're stressed is that our perception of time completely goes out the window. How many of you guys were here for the Loma Prieta earthquake?
Yes, I was.
So how long did that feel like it took? It seemed like a really, really long time. Most people say it felt like it was 5 minutes. I think it was 42 seconds, if I remember correctly. And that's one thing about when you put direct pressure on a wound, it may seem like you've been doing this forever, and it may not have been that long. And it may be that it does take time.
So just as an example of that, in the operating room, if we put an arterial line in somebody in the radial artery, which is a relatively small artery, this allows us to directly measure blood pressure. If you are either going to take that line out, or if it didn't work for whatever reason, we have to hold pressure on that for 5 minutes at least, or that can start to rebleed.
Yeah. So because well-aimed direct pressure, that's taking your hands. This is where doing a response is really a team sport. That If the patient is conscious, and then having them hold direct pressure is very useful. Or if you have other people that you're directing, that then having one person holding that direct pressure can be very helpful. So if it's not working, ask yourself, is it well aimed? Am I providing enough pressure? And I always say, no peaky, no leaky. You don't want to be looking at it as it stopped, has it stopped, has it stopped, because you want to keep that pressure on it. Now, if the wound is on an arm or a leg, and you've got significant bleeding that is not stopping, there is the opportunity to use a tourniquet. And this is something that has, for a long time, we actually did not teach tourniquets because we thought that it was too high a risk to benefit ratio. But we've really discovered that it is profoundly effective and really a life-saving tool and technique. And that is something that we will go over during the in-person skilled stay.
Cam,
Yes.
I was wondering if we're going to be doing the shaving cream on the gloves, then remove the gloves exercise.
Absolutely.
That's really fun for everybody. I took the class originally from Mikey. I remember you. Hi. Oh, here, I'll put
How are you?
good. I'll put my face on there.
Hey,
Good.
Carol.
Yeah, that's a fun thing to do and figure out that it's harder than you think.
Mm-hmm. Absolutely.
Actually, it might be good to demonstrate it even in this class, because we don't know when the next time we're going to need to use gloves on someone is going to be.
Well, actually, I'll take the opportunity right now just to describe it, and I encourage people to do this at home. And that is, you've got gloves, go ahead and first review the video that shows you in terms of taking it off, or we can also send one out. But put something like shaving cream, or I like actually using ketchup myself, and put it on the gloves and practice how to safely remove the gloves so that you don't come in contact with the outer contaminated gloves. I have a dog. I must say that being able to use this for picking up poop, fantastic. But one of the things to be aware of, like all things in emergency response, slow and smooth is what's going to let you go fast. So it's something that you don't want to do it quick, because then it's going to make a mess. And then you're putting yourself at risk. And so I want to take just a kind of use that as a segue back to with scene safety. You will never see a paramedic or a firefighter or a professional responder running to the scene. Part of that is because they are doing that scene assessment. But the other thing that they're doing is that they are keeping themselves calm so that they can make good decisions. All of us, if we get excited, it's like the blood is leaving our frontal cortex. Our ability to think, no matter how smart you are, if we're stressed, we get stupid. And so the act of deliberately taking your time, doing a deep, slow breath, that time will make everything else be more efficient and be faster. So that's a little bit of a segue, but when you take your gloves off, do it slowly. Okay, any other questions about bleeding at this point?
Do you have any advice for anybody who's queasy about blood? And that's not me, but.
Well, one of the great things about this being a member of the CERT team is that there are many different roles that people can play. And while medical response is one of them, it is not the only one. And so I think that it's really important for people to play to their strengths. It may be that being a radio operator or being a scribe for command staff may be a more effective use of your skills. And so that's something that is good for people to know. The other thing about is also developing the right mindset. Because one of the things that you'll find is that a lot of it is putting things into context and realizing that there's things that might have at one point you thought was really scary. When you realize that in fact that's not going to kill someone right now, when you realize that it becomes less frightening with time. So there's this whole concept of stress inoculation. So partly when we do exercises, when we do thought exercises, part of that is so that when we see it for the first time, it will not be the first time that we've experienced it. So that's one technique. That said, I also know some people that they're just squeamish around blood, and that is a visceral gut response on their part, and you should respect those boundaries.
And even people who may not be squeamish around blood, like me, I spent my whole life in it. It's very different when it's your family member or your next door neighbor. And it's not something to be ashamed of if it happens.
I have another question about bleeding. Can you hear me?
Yes.
Okay. When we were talking about whether or not you should remove a dressing that has been placed on bleeding or not, would it make sense that if you're starting to get a pile of dressings, that you might remove some of the topmost ones but not the bottommost ones that would be directly in contact with the wound? Would that make sense?
The idea is that gauze that is right against the wound, that is becoming the clot. That is in fact the clot itself. So you don't want to remove that.
Right.
But I think that there's a balancing act that you also, if you have such a large pile of bloody gauze that you don't know that if you're getting really good direct pressure, Michael, I'd really like your input on this. My sense is to go ahead and take the top levels off.
Yes, absolutely, because you hit it right on the head, Cam, is that first layer, that second layer, that's the clot, right? So that's the one that we want to avoid peeling because we don't want to peel the clot. Versus now you say you have a stack of 3, 4, 5. Yeah, absolutely, we can remove the top 2 because that's not going to pull the clot away. The objective is to keep the pressure, keep the clot going without trying to disturb it. The no peaky, the no leaky type deal. So absolutely agree with you 100%.
So Mikey, would you say that like if I'm taking the outer layers off and it starts to stick a little bit, just leave that on?
Exactly.
Okay.
Exactly. That's what you don't want to disturb.
Right.
Okay, thank you.
Any other questions about bleeding control? So one thing I do want to add is that if you're taking, and actually I must confess, I don't actually recall whether or not this is in our hands-on class here, or if this is something that I've done in other first aid classes. But something to be aware of is there's a concept called the pressure bandage. And so the idea that you use actually a bandage to help hold pressure. And so at some point in time, I'm not going to go over it in detail today, but be aware that there is the possibility of using a bandage itself in putting pressure. It's not likely to be as good as you holding it directly. So that's only if you've got more wounds than hands. Okay. So we talked about the first thing that you need. You need oxygen going in and out. You need an open airway. You need to have the blood to hold the oxygen. When we talk about shock, shock is when, for some reason, that blood isn't getting to the vital organs. And by vital organs, we're meaning the heart, the brain, the liver, and the kidney. And without that oxygen, that tissue starts to die. Now, we'll go over this in a lot more about how to recognize shock and what does it look like when we do the triage module. But if someone is not getting if someone is going into shock, if their brain isn't working very well, one way of kind of testing that is just, can they follow a simple command? If you say squeeze my hand and they can't do it, that gives you information that something is wrong with the brain. We don't know what's not right with the brain, but one of the things that it could very easily could be is that it's not getting oxygen, it's not getting the oxygen it needs. We also talk about how we can tell, is oxygen getting to the tips? And the idea of capillary refill. And that's where you squeeze the nail bed and then release it, and you look and see, does the color come back? When we do the hands-on training, we'll go into some more details about that. And then there's also if someone's doing shallow, rapid breathing, that's not very effective. And so, but it may be that they're not getting a good, strong breath. Now, there are lots of things that can cause shock. I like to think of it as our system. We have a pump, we have pipes, and we have fluid. And if something's not working with one of those, then we might not be getting an effective flow of blood, of oxygenated blood. It may be that there's not enough fluid. And we've talked about that with loss of bleeding. It could be that their heart, the pump itself, isn't working. Fancy name for that is cardiogenic shock. It may be that the part of the brain that controls the size of the blood vessels may be out of whack, and it's due to head trauma. It may be because the temperature range, that we have a pretty narrow band of what we can handle in terms of temperatures. And when you're too hot or too cold, you can be going into shock. And then there's the slower shock. If someone gets an infection, it is possible for that infection to affect not the number of pipes, but basically it can make the pipes leaky. So even though you have even if you have plenty of fluid, and even if the pump is fine, if all of your pipes are leaking, you're not going to get oxygenated blood to where it needs to be. The infection we're not likely to see immediately, but the way that we treat someone now has an effect on what's the likelihood that they're going to get an infection later. So when we talk about using sterile gauze, when we talk about using clean water, that's because of the long-term effect. That second level that doesn't take place immediately can be just as deadly. So what can we do about shock? Big one. We've already talked about this. Stop the bleeding. Stop the loss of the blood. Also, if they're not already lying on the ground, assist them to the ground. Make it easier for the body, for the blood flow. Don't have them fighting gravity to get it to the brain. And the other thing is that we use a lot of energy keeping ourselves being a warm-blooded animal. And someone who is going into shock is very vulnerable to heat loss. And so what we can do is, if someone's in wet clothing, don't leave them in that wet clothing. And a huge source of thermal loss is through the ground. Get some insulation underneath them. Especially when we're standing up there, we might not be as aware of it, but get a blanket underneath them. Also, if you're using emergency blankets, be sure to have the reflective part on the inside. And one tool that I highly recommend in people's emergency kits is actually wool blankets. Not only are those those are effective as insulation, they're effective even when they're wet, and they can also be used as fire blankets. So, Vicki, Michael, anything you want to add about shock?
No, I think you hit it all on the head. Also maintaining the body temperature. I know on the other one, it did say hyperthermia. So someone that's hot, like a heat emergency. Just always remember, when we're going to actively cool somebody down, you don't want to induce shivering. And the reason why you don't want to induce shivering is that's the body's natural way of trying to heat back up, right? So you're almost being counterintuitive by cooling them down, but making them shiver. Their body's going to try to heat itself up. So you want to slowly cool them down without inducing that shivering. But great job so far. I like it.
Cam, it's Vic. Yeah, just one observation I remember from the exercise when we went through the training was the issue of denial. I know I missed somebody walking by me in the middle of the exercise. I'm fine, I'm fine. And I finally picked up that she was like walking around, the actor that was doing this, that it's very common. And that was a real learning point for me. I just didn't realize that people in shock often automatically deny it. And that you've got to really focus on them if they're showing any of the signs that indicate that they really are either going into shock or some phase of it that requires some treatment.
That's a really good point. Yeah. The other thing about shock is that it's a heck of a lot easier to keep someone out of shock than to get them out of it once they're in. And so prevention is incredibly effective, incredibly important. So any other questions about opening airways, about bleeding, about shock?
Yeah, I have a quick question.
Yeah.
Can you hear me?
Yes, we can hear you.
Hi. I have a question with. Yeah, okay, thank you. I have a question with regard to passerbys. If you are in need of assistance and you see somebody that's uninjured and they are not CERT trained, can you ask them for assistance if you need assistance?
That's a really good question. I'm going to actually ask Mark to respond to that from a CERT perspective, but my gut, I honestly don't know if like under the guise of CERT. I do know that when I am just doing first aid on an individual basis, that making use of bystanders is incredibly valuable and incredibly important. And that you can use them very effectively to control a scene. You just need to make sure that you're not asking them to do something that is outside of their skill set. But I'm going to pass it off to Mark in terms of the official CERT response.
Yeah, Cam, you said it perfectly there. In that case, you can ask somebody to assist you. They would be doing that under the Good Samaritan law. You should not expect them to do anything outside of their training or expertise or willingness to assist you. And you would want to supervise what they're doing. But that's kind of an edge case that would be a little bit unlikely to happen. But again, it goes down to Good Samaritan law protects the person that you're asking to help. And then it's your job as the CERT member to make sure that anything that they're doing, you're supervising, and that it's within their scope and their willingness to help you.
In fact, in the mass casualty scenario, the video that we used to show, you even ask victims that are okay enough to do it to help put pressure on somebody else's wound. So you kind of just have to assess who the help is and use what you've got. If you're in a scene where you need more hands than you have.
And we'll actually talk about this a little bit more in disaster psychology, and also talking about team dynamics. In many ways, by choosing to take that leadership role, and you are providing many bystanders with a gift of something to do. A lot of times people want to help, but they don't know how. And so by giving them clear, direct guidance of, I need you to stop traffic over there, I need you to hold pressure here, that I know that for many of us who were not assertive when we were young, that feels awkward, but you really have to realize that you are providing a profound opportunity for people because they want that guidance very much. Okay.
Yeah, thank you very much. Yes, that answers my question. Thank you.
Yeah. And in fact, that segues nicely into, while you're doing this, I want to point out that how we behave, having that calm, clear demeanor, is a form of medicine. That when we can be, I mean, this is dynamic stuff, but the more that we can be calm ourselves, the better that we can help others. You'll hear some responders say, I'm not having an emergency. You're having an emergency. I'm not having an emergency. And it sounds callous at first until you realize that what you're doing is that you're making yourself more effective and you're able to be more supportive. I think of a lot of people who are injured as being, hang on just a second, hush. Sorry. That a lot of times people are like a little kid who's running the street and they've scraped their knee and they don't know how hurt they are. And they're looking to you, and how you respond changes how they feel about it. And so by having that calm, cool demeanor, that really helps them be calm and cool. And the other thing I'd like to just point out is that when you ask someone a question, that using very clear, simple language and give people a chance to respond, especially if they're stressed. It may take them a little time to formulate the answer. Give them that little bit of time and don't ask them another question while they're still thinking of the answer to the first one. So we've just got a little bit of time left. That was all about life-threatening injuries. And the reason why we spent as much time on that is that that is what is time critical. That's where how fast we respond is going to make a difference immediately. And honestly, nothing else matters if you don't have that open airway, if you don't control bleeding, and if you don't treat for shock. So there's a lot of other specific kinds of injuries that were discussed in Unit 3. But I really want you to think of them in terms of when we are doing basic first aid, we're kind of continuing to maintain our situational awareness of is there something else that could be life-threatening, and really seeing it through that lens. We're also seeing it through the lens of how are we going to prevent further injury, and also how are we going to promote recovery later on. So we're going to have a chance to talk about specific ways of treating, of specific techniques for these different kinds of injuries. We're not going to get a chance to talk about them in any depth today, but I encourage you to use the discussion list that as questions come up about specific topics, please do post those. I also wanted to point out, just like, because I am mentioning a lot today, the hands-on skills. If you want to see what are the things that we're going to be covering, if you go back to that front page of the online course, that there is a link there that links to the skills checklist. And so as an example, for Unit 3, here's a list of all of and we're going to go through every single one of these. Well, except for the ones that say optional. The ones that say optional, we may or may not go over. But this gives you an idea of before we have the in-person class, we'll have you review the manual and look at this, and then you'll get a chance to do the hands-on skills. So next week, we'll start going into Unit 2, the Part 2 of Disaster Medical Operations. We'll get into more doing the head-to-toe assessment. So we really have been talking about what's going to kill them right now and some basic techniques of first aid. But then we'll get into more of okay, now we're doing a head-to-toe. Now we're doing how do we manage medical operations? How do we organize this? And there's a concept called triage that you may if you've taken the class before, you might recall that there had been a unit specifically on triage. That is not inside the University of Utah's version of the class, but it is going to be in the version that the state of California. They haven't posted it yet, but when they do post it, we are going to ask everyone to go through that. And so we will discuss that a little bit. Are there any other questions? I know that that's a lot of material, and I've been only partially successful in keeping me being the one talking down. I need you guys to help me out with that next time. But any other questions that people want to talk about at this point? There was one saying that they liked the idea of a mental triage exercise. I think that's a fantastic idea. And I think that we will be doing some of those tabletop and mental exercises.
I'm just wondering, how necessary is it that we put our CERT vest on when we're acting as a CERT?
If you are, so again, as Mark had pointed out, you're not going to be like, if you're responding at a just at a neighborhood level and you have not been activated by CERT yet, then you should not be identified as CERT. It's once, and Mark, please correct me if I'm wrong, but it is only once the CERT activation has taken place that you should be identifying yourself as being CERT.
And I'm wondering, what if you can't locate, I mean, I should be able to, but what if you can't grab your CERT vest in time? Can you still participate?
I'm sure we can find a way to have you participate. We may even find another vest, but yeah, no, it's a very, very useful tool, but it's not the ticket to entry.
I agree, Kim.
Okay. I'm not seeing any other questions, but I want to.
One more for you.
Oh, please.
When we do the big exercise, I forgot the name for it, but will they be using the blood makeup and all that?
Moulage, my favorite. That's actually a good question. This is the first time that we've done the hybrid course. And so this is the first time that we've done so I don't know, I kind of suspect that we won't be using moulage extensively in the CERT class section, but certainly when the time comes that we can do big drills, the moulage, the fake wounds is definitely a part of it.
Yes, this is Selena. It's absolutely, as much as we can use it, we absolutely do to give it a more realistic feel, Carol.
And a lot of that is because this whole concept of stress inoculation is that if coming around the corner and seeing someone with a bloody face, if that you have a chance to experience that and to learn how to be even more effective, that having to address that emotional response. So we don't do it to scare people just because it's fun. Okay, it might be a little fun. But no, seriously, it is because it helps us be better responders.
Yeah, the only thing I can think of is, I'll give you feedback from my experience during the exercise. And they had the high school actors, and they had this one girl, she was just continuously saying, "Where's my baby? And where's my baby?" and pulling on me. And it was a bit much. So
There
I
is
encourage them not to overact.
There is an art form to standardized actors. And actually, just as an aside, this concept of using makeup and using actors is something that is used for medical schools, and sometimes people are better actors than others. And just like actors on a screen, the ones that are able to convince you of it being realistic are going to be much more effective than ones who overact. So that's an ongoing.
Also, I think there's something to be said for it being a bit much, because that's what it's going to be like in a real situation. I mean, there's not going to be backing off of victims that are going crazy. So it's in some ways it's instructive, I think.
And I want to add to that is that, you know, we're lucky enough to be able to utilize the theater people or the theater students from the high school. And I'm usually scrambling around trying to find people to play patients. And so, yeah, it is definitely an art form, and having time to prep them. We're getting better every exercise and prepping them beforehand. So hopefully this next time around, we can find a even better balance, but we absolutely, that they're crucial. They're integral for this
Absolutely.
Oh, yeah, I'm not trying to complain. It's just the chiefs on the way out, I said there was an awful lot of screaming.
And that, to be honest, that is something that is, if it stresses you out, I think like Vicki said, there is actually some benefit to that, because if it gives you some strategies for not being stressed, then it's a good thing. But that is a balancing act for sure. So I
And
want to respect everyone's time and just end by saying thank you so much for being here. And please do continue to put questions on the discussion list. And we look forward to seeing everyone next week.